So I'm going to be talking to you about 2D versus 3D transthoracic echo for tricuspid valve anatomy. So a long time ago, when we looked at the tricuspid valve, we used M mode. And you can see that on M mode echocardiography, you cannot really appreciate those tricuspid valve leaflets. More recently now, we've been using 2D echocardiography, and with 2D echocardiography, you need to obtain at least 3 different views to be able to see all 3 leaflets of the tricuspid valve. And even then, as you will see in the next few slides, you may not be seeing all 3 of those leaflets. So now, with 3D echocardiography, it's possible to see the tricuspid valve both from the ventricular perspective and from the right atrial perspective. And when you look at the valve from the ventricular perspective, you can see the septal leaflet here, the anterior leaflet here, the posterior leaflet here. From the right atrial perspective, you see the septal leaflet here, posterior leaflet here, and anterior leaflet here. With 3D echocardiography, you can also see things that you did not expect. This, for example, is a series of patients with malcoaptation. You can see that the malcoaptation of the tricuspid valve is not all the same. Not all patients, even though on 2D echo you cannot tell this very well, but on 3D you can see this is a small malcoaptation, bigger one, much bigger one, a gigantic one. We can also look at the number of leaflets. We know that tricuspid valve is supposed to be tricuspid, so it should have 3 leaflets. But we are now realizing that you can actually see tricuspid valves which are bileaflet or bicuspid, as you can see here, even quadricuspid tricuspid valves. And pathologically, people have described up to 8 leaflets of the tricuspid valve. So the tricuspid valve complex has 3 leaflets, the anterior, the posterior, and the septal. It is also made up of the chordae, the 2 papillary muscles, the fibrous tricuspid annulus, the right atrial myocardium, and the right ventricular myocardium. As was mentioned earlier, the tricuspid valve, like the mitral, is also saddle-shaped. And when we talk about the added value of the third dimension, you can see from here that on 2-dimensional echocardiography, you can only see the 3 leaflets simultaneously in less than 5% of patients. But with 3D echocardiography, we have found that in about 80–85% of patients, you can actually get reasonably good images of the tricuspid valve and be able to see all 3 leaflets simultaneously. So this is a case of a patient at our institution who was going for an LVAD. Now, with these LVAD patients, it's important to determine whether or not they have tricuspid regurgitation. And you can see here, now this one was playing but hasn't, I think it's important that it plays, so I'm just going to move back 1 slide and move forward again. Or, oh, it won't play. But in this image here in the RV inflow view, these 2 leaflets come together. In the 4-chamber view, the 2 leaflets here also come together. But this patient actually has torrential tricuspid regurgitation. And what we did to try to figure this out, so you can see the 2 leaflets coming together at the RV inflow view here. So what we did to try to figure this out was that we took a full volume view in the RV inflow view. And with that full volume 3D data set, we opened it up using multiplanar reconstruction. And what we realized was that this 2D plane is actually cutting the anterior and the septal leaflets. And with a slight change in the probe position, as you can see over here, suddenly you appreciate malcoaptation of the tricuspid valve leaflets. If you do a full volume 3D here, and open up that data set, you are actually cutting the anterior and posterior leaflets. So suddenly you get an appreciation for the planes of 2D, where you, in this case, for example, you look at this image here, which is not playing, but when the image was playing, you saw the 2 leaflets came together, the anterior and septal leaflets. And this here, where there's a malcoaptation, you're actually cutting to the anterior posterior leaflets. So suddenly it becomes possible to discern perhaps discern TR pathology using 3D of the tricuspid valve. Another important question that people have been trying to answer is which leaflet do we see in which view? Now, we learned from the textbooks, and we are taught for the echo boards and so forth, that in the 4-chamber view, we should expect to see the septal anterior leaflets. In the RV inflow view, the anterior and posterior leaflets, and in the basal short axis view, although the 2D echo does admit to variability here, septal anterior leaflets. Now we and one other group have done a study on this, and what we looked at about just over 100 patients. And in these patients, when we looked at the RV inflow view, 80% of the time we were actually seeing the anterior and the septal leaflets. And the way we did this was, as I showed you before, to take a full volume data set in the same position in the same prone position where you obtain the 2D RV inflow view, use that full volume 3D data set to tell you where the 2D cut plane is cutting. And so what we found with our RV inflow views is that 80% of the time we had the anterior and septal leaflets, 26% of the time we saw anterior and posterior leaflets. In the apical four-chamber view, 96% of the time we were getting septal leaflet and posterior leaflet. And always the septal leaflet will be on this side, but this leaflet in 96% of cases was actually the posterior leaflet. And this was all done by one sonographer. So it is possible that there are intersonographer variations. And only 10% of the time in the apical four-chamber view are we actually getting the septal leaflet and the anterior leaflet. Now the basal short axis view was very variable, and 43% of the time we were getting the anterior and posterior leaflets, 24% of the time we were getting the posterior and septal leaflets. So our conclusion here was that it is really not possible to be sure what leaflets you are imaging of the tricuspid valve on 2D echo. So we tried to come up with a series of views with the help of 3D echocardiography, a series of views using 2D echo where you could be sure of what leaflets you are imaging. So we found that if you take an RV focused view and include the septum, if you include the septum in your RV focused view, you are imaging the septal and anterior leaflets. If you have a basal short axis view with the aortic valve and you only see a single leaflet, that is the anterior leaflet. If you see the basal short axis view where you have two leaflets that coapt in the midline and you see the aortic valve, you are imaging the anterior and posterior leaflets. If you are in the apical view, you see the left ventricular outflow tract, you are imaging your septal and anterior leaflets. And if you have the apical four-chamber view and you are imaging the coronary sinus, you are seeing the septal and posterior leaflets. So I'll show you an example of how this becomes useful. So this is a patient who's obviously got some tricuspid valve pathology here. And when you look at the patient with the LVOT or the image with the LVOT, you can see there's prolapse here, but you don't quite understand where the prolapse is happening. If you look, on the other hand, at this image, which is not playing at the moment, but when it does play, let's see if I click it, will it work? It doesn't want to play. But when, let me try one more time. So when it does play, you can see, first of all, this is the coronary sinus in the back here, and there doesn't seem to be anything wrong with these two leaflets. That's the septal leaflet and the posterior leaflet, according to the slide that I previously showed you. So if there's pathology here, it seems like that the pathology is in the anterior leaflet. So there's anterior leaflet prolapse, and that is the reasoning that you make on 2D echocardiography with these two images. So let's look at what 3D tells us. So with 3D echocardiography, we can clearly see, this is the right atrial perspective, looking at the tricuspid valve, the septal leaflet, posterior leaflet, anterior leaflet, there's anterior leaflet prolapse. So it is possible using 2D echocardiography and those views to be sure where your leaflet pathology is. So one of the tricuspid valve disorders are divided into two types: tricuspid stenosis and tricuspid regurgitation. We're not going to spend much time on tricuspid stenosis. I'm going to focus more on tricuspid regurgitation, which can be either primary or secondary functional. The most common type of tricuspid regurgitation is primary tricuspid regurgitation or secondary tricuspid regurgitation, which is in 70 to 85% of patients. And with 3D echo, when we look at causes of primary or organic tricuspid regurgitation, sometimes you can see more clearly the pathology behind the tricuspid regurgitation. This is an example of a case. And if maybe I'll go back and forth, see if that works. It doesn't work, but you can see this patient actually had billowing myxomatous leaflets, and we have an example of this on the computer, so on the laptop I'll probably show you that one. And here you can see from the right atrial perspective that all the leaflets were prolapsing into the right atrium. So this is another example of primary tricuspid regurgitation. In our lab, we've done some work looking at 3D echo and the usefulness for primary tricuspid regurgitation associated with pacemakers. This is an 89-year-old man who came with right heart failure, ascites, and he was sent for a transthoracic echo. He had a past medical history of a TAVR in 2009 and had pacemaker implantation post-TAVR for bradycardia. If you look at his 2D echo, you can see that there's a pacemaker lead out there in the background. You don't see the pacemaker lead very well. That is typical on 2D echo, not to be able to see the full extent of the lead. But interestingly, when you look here, you can see that there are two jets of tricuspid regurgitation. One is coming from the coaptation point between the tricuspid valve leaflets, and the other one is coming from here. So you wonder, could there be a perforation of the leaflet? And indeed, on 3D echo, you can see there's the pacemaker lead there, seems to be perforating through the posterior leaflet. Now this is again looking at the tricuspid valve from the ventricular perspective down. You can see septal leaflet here, anterior leaflet here, posterior leaflet here. And you can see how that pacemaker lead seems to be going through the posterior leaflet. So that also agrees with what we see on 2D echo. So one of the things that we have done in our lab was to try to look at these pacemaker leads and try to localize them based on what we see on 3D echocardiography. And what you can appreciate is that leads can be in various different positions along the tricuspid valve. They can be in the commissures. This is an example of a pacemaker lead in the posterior septal commissure. They can be up against a leaflet, so impinging on a leaflet. This is a pacemaker lead up against the septal leaflet. This is another pacemaker lead up against the posterior leaflet, impinging on the posterior leaflet. Let's see if we can get that to play. So I don't know why these don't want to play. But this one here was an example of adherence of the pacemaker lead to the anterior leaflet. And okay, this one is playing. You can see the two leads. One is in the posterior septal commissure, and the other one is probably in the middle of the valve. And then here, this is an example of a lead that is in the right place. It seems to be in the posterior septal commissure, but there's still malcoaptation of the tricuspid valve leaflet, suggesting this might be some pathology within the chordal apparatus. So what we discovered was that if you take patients who have impinging leads, and patients who have non-impinging leads, so meaning patients whose leads seem to be impinging on 3D echo upon one of the leaflets, either the septal, the posterior, or the anterior leaflet, or patients who have pacemaker leads that are in the commissures. There's a difference between these patients. So patients with impinging leads are more likely to develop tricuspid regurgitation, are more likely to have tricuspid regurgitation associated when you compare their pre and post lead implantation echocardiograms, whereas non-impinging leads tend not to have tricuspid regurgitation pre and post lead placement. And this is interesting because it shows you that 3D echocardiography might have a role to play in deciding on whether a pacemaker is impinging upon a leaflet. So some people don't believe this, and I think we saw a case actually earlier this morning showing that these pacemaker leads can really encase those tricuspid valve leaflets. And this is actually a 40-year-old man who came with right heart failure, severe TR. You can see the course of his pacemaker lead actually on the 3D echo. And then he actually had two leads. And you can see one lead seems to be okay here, and the other lead is encased within the tricuspid leaflet. And he ended up having a bioprosthesis. So let's take a look at a couple of cases. And these are data sets that we stored, and Megan Yamat is going to tell us about these.
These are all transthoracic echo examples of 3D zoom acquisitions of the tricuspid valve. And we can see nicely that it seems to be that there's prolapse of every leaflet here, kind of like the Barlow example of the mitral valve, but for the tricuspid valve case. So I'm just going to show you how I crop in, and obviously depending on the pathology, where you're going to look. Now in this case, we're going to be looking from the right atrial perspective because we're looking at prolapse. However, to orientate myself, I like to go from the ventricular perspective, sort of put that septum down so I can know exactly where I'm going to be cropping into. So once I've put my septum down, I'm just going to go in here and make it a little bit easier for me to manipulate the data set. Okay. I'm going to turn it on this perspective, so now we're looking from the atrial perspective. And I'm just going to crop in with my crop adjust plane. There we go. And I'm just going to crop this down in the atrium. And then I want to do my image adjust and turn down the gain. And before I crop too much, I'm going to turn it off and just see how well we can see it, because I don't want to take too much of the tissue away. And then you can always just readjust your plane from there. I like to turn down my gain, increase my brightness, decrease my compress, and then increase my smoothing a little bit. Then once you're happy with that, you can turn off your crop adjust plane and you get a sense of how these leaflets look. And then we'll go look at some other cases which have other pathology. So again, we're going to go in here, and these are transthoracic echo images. And I'm going to put my septum down, and I'm just going to turn this so I can make it a little bit easier for me. And this one, I really don't have to crop too much in it. I'm just going to decrease my gain. And I'm going to play, and this is a lady who came in to the ER, as you can see, with fever and chills, and you can see there's a large vegetation here. And this is going to be our septal leaflet here at the bottom. This is our anterior leaflet and our posterior leaflet. So now we can actually isolate where the vegetation is affecting. And this vegetation is in fact on the anterior leaflet. Now here's another case, and I have it cropped in, but again, I'm going to show you. And again, these are transthoracic images. And you can get a sense, when we do TE on patients, we really can't get a sense of the tricuspid valve anatomy because of the angle, but on transthoracic imaging, we can really get some nice images. So I am just, this time this is from the ventricular perspective, so our anterior and our posterior leaflets are going to be switched. And I'm just going to use my crop adjust plane, so I can crop off a little bit of this tissue here, so we can get a better sense of what's going on with the valve. And I'm just going to crop this down. Perfect. Take that off, and I'm just going to turn down my gain just a little bit. And now we can see there's a large malcoaptation point. You can get an appreciation of the septal and the posterior leaflet seem to be completely tethered in this patient. Anterior leaflet is trying to come in, but we see the tethering here. And we get an appreciation because on our transthoracic images, we can't see all three leaflets of the tricuspid valve simultaneously. And then we can go from the right atrial perspective, which is going to be from the surgeon's view. It's going to be our anterior leaflet, our posterior leaflet here, and our septal leaflet.
So you can see how the malcoaptation here involves all three leaflets, whereas in that other case that I showed you, there was only two leaflets involved.
Yeah. And again, just depending on where the malcoaptation lies. On your 2D imaging, you might see your leaflets come together, and you can underestimate your TR or even the mechanism of TR in these patients because maybe you're missing that malcoaptation point depending on where it's occurring. However, when you do 3D, you can see the picture as a whole as to where exactly the malcoaptation lies.
Okay. So we talked a little bit about primary organic tricuspid regurgitation and did a few examples. But as we said before, the secondary or functional tricuspid regurgitation is the most common. So in secondary tricuspid regurgitation, which accounts for about 70 to 85% of TR, you see right ventricular dilatation, tricuspid annular dilatation, tricuspid leaflet tethering, and right ventricular remodeling due to pressure or volume overload. And in these patients, the cause could be left heart disease with PH, any cause of pulmonary hypertension, RV dysfunction. So we learned about 10 years ago that tricuspid annular dilatation, and this was also mentioned this morning, tends to occur along the septal lateral dimension, so along the free wall of the right ventricle. And this study was done by the same group, Dreyfus and his group, and what they showed was that performing a tricuspid annuloplasty based on tricuspid annular dilatation rather than tricuspid regurgitation degree results in improved surgical outcome. So if you see here, patients who have had both mitral and tricuspid valve repair, their survival is similar to those who have mitral valve repair only, but and these are all patients who have got dilated tricuspid annuli, but their morbidity is better in this study. So the question for echocardiographers is that if we are going to measure the tricuspid annulus, where should we be measuring this? And one of the things that we know is that tricuspid regurgitation is very preload dependent. So if you look at TR here in this patient, it looks like trace, maybe mild TR. However, if you measure the annular size here, this patient has a dilated annulus. The guidelines, as we talked about earlier today, tell us that tricuspid annular dilatation is important because patients with mild or moderate tricuspid regurgitation who are going for left-sided valve surgery, if their tricuspid annulus is dilated, then there's a class 2 indication for repair. But the question becomes, how should we measure tricuspid annular dilatation? Should it be an intra-op thing? Should the surgeon measure it? Should it be 2D echo or should it be 3D echo? So a recent study actually that was published in Circulation Imaging last year showed that if you measure the tricuspid annulus intraoperatively by the surgeon, there is a moderate correlation with the tricuspid annular diameter we obtain on the apical 4-chamber view. And it's actually the apical 4-chamber view on transthoracic echo that is recommended on the valvular heart disease guidelines as the place to measure your tricuspid annulus. But the thing about the surgical measurement is that there's a lot of variability, a very high standard deviation. Now, Dr. Badano's group recently published a paper looking at the different locations where we can measure the tricuspid annulus size in the RV inflow view, the apical 4-chamber view, and the basal short axis view. And what they found was that the feasibility is greatest for the apical 4-chamber view. The feasibility of the others is not so great. And actually, the basal short axis view feasibility was only 55%. But what we know is that 2D echocardiography underestimates the size of the tricuspid annulus. This is all from the same patient. You can see that when you use 3D echocardiography, the tricuspid annular dimension is 43 millimeters, whereas with 2D, we obtained smaller measurements. So then the question becomes whether 3D echocardiography should be, whether we should be doing research to look at whether 3D echocardiography should be the ideal way to measure these annuluses. And we've been doing some work on this in our lab. And one of the things that we've been successful in doing is coming up with a software that is capable of analyzing the hinge points of the tricuspid valve in rotated planes, allowing you to actually obtain area of the tricuspid annulus over the cardiac cycle and perimeter and long and short axis dimensions. So this might be the future of tricuspid annular measurement. And one of the things that 3D echocardiography would enable you to do is to obtain 3D printing of the tricuspid annulus, which maybe in the future would be a way in which we customize prosthesis and annuloplasty rings for these patients. So thank you very much.